Good morning, everyone. Just making sure I have the right connection. Hello, welcome to the PT on Ice Daily Show. My name is Jessica Davis, and I am here part of the ICE faculty, and I teach the Performing Arts Division, but I also teach some of the cervical and lumbar cases or courses. Today I'm going to talk about a subject that's near and dear to my heart, and that is of differential diagnosis. So the reason that I wanted to pick this topic today is I realized that we talk a lot about differential diagnosis in school, and we also hopefully, good morning everyone, hopefully we go over this topic frequently and yearly. But this is something, when you have a patient and you have a case that changes your life, it can be a case like this. And I thought this was a great example of something that permanently changed my practice, the way that I evaluate patients. But before I get started, I do want to mention a couple things. So for those of you who are not familiar with Virtual ICE, what an amazing mentoring opportunity. So right now it's open. So what Virtual ICE is it's an opportunity to have mentoring. So the ICE faculty meet bi-weekly and they go over different topics, and they will have live lectures, and it's open for discussion. And it goes from March 19th, and after that it closes and it won't reopen until the end of June. So what an amazing opportunity to do this. If you're interested in learning and having peers that you can go back and forth and ask questions. And it's $30 a month, $29 a month actually. So that's an amazing situation. So I would consider that. And also coming up in April, don't forget, we have the ICE Sampler Platter that's going to be in Vegas, and that's April 7th and 8th. And we have 9 faculty coming. So what an amazing opportunity to meet everyone and also learn about all sorts of different topics where everybody's passionate about these things, and go back into the clinic after a weekend like that and utilize all these skills. So wanted to mention that. Okay, so if you notice I'm in a different location, I'm not at Point Park today, and I'm not working with my dancer, and that's because I wanted to take an opportunity to talk about something more in the orthopedic realm of what I do every day, and that is differential diagnosis. So when we have a patient who has thoracic pain, okay, so this was a patient who was 45, and she came to me with right-sided thoracic pain, and it was insidious in nature. So anytime something's insidious, that should get your brain firing, and you should be thinking, okay, why did this develop insidiously? Now we know that region sometimes in the spine things can develop insidiously. It could be postural in nature. So that's the important part of the subjective exam. The subjective exam, if you go to any of these ICE courses, we hopefully drive the importance of the subjective exam home to you. And that's because it is the most important part of the exam. It's the moment where, number one, you connect with your patient. Number two, you are using all of your skills to really figure out what's going on with your patient. And that's why you need to establish those subjective asterisks and objective asterisks that you test and retest using the test-retest model each and every time you treat your patient. Because when we think of red flags, we can pick up on some of those the first day when we work with a patient. But something that we often miss, and I see it happening in the clinic, is we'll miss when a patient fails to improve, right? And even trickier than that, when a patient of ours improves a little bit or even greatly, but then you get that waxing and waning of symptoms. So if you over a time period get a trend that isn't a gradual improvement, then number one, you need to think about as a therapist, what am I doing with this patient that I need to change? And that's what helps us with the test-retest model and keeping and checking in with those functional and subjective asterisks. But if despite all of our efforts, if a patient is not significantly improving over time, that's a red flag. That is something that you have to think about. So this patient of mine, she was 45. She came to me with right-sided thoracic pain. It was insidious in nature. She reported that lifting heavy grocery bags would aggravate that right side. She said after sitting for sustained periods, she would notice it. She also said at night when she would be sleeping that she would get this pain. It would wake her up. But when I asked her about that, she said when she changed position, she was able to fall asleep. So I thought, okay, so That's not typical if we think mestatic. We think that it's going to be something that they're going to have difficulty falling asleep, or potentially it's going to wake them up at night and they're going to have difficulty returning back to sleep, also with inflammatory conditions. But let's talk about the thoracic spine. So it's a common referral region. It can be referred from the neck. It could be referred, you could get referred pain from the shoulder, obviously anything in the thorax, but it could also be cancer. It could be pulmonary in nature. It could be renal, GI. So infection, and then you got to think about a potential for fracture. And that's why the specific questions that you ask in that subjective exam help you refine. It doesn't have to be an hour-long subjective exam, but you need to be very specific with your questioning. So when I asked this patient about her symptoms, I asked her, I said, does it change when you eat? If you eat a meal, if you're full or if you're hungry, does that change your symptoms? And she said, no, it doesn't. And I asked her, has she had any weight loss? And she said, no, I haven't had any weight loss. And I said, do you feel fatigued? Do you feel any, how's your energy level? And she said, well, my energy level isn't great. She attributed her energy level to being, having the fact that she's being awakened frequently at night because of the pain. But she also, when I delved into her social history, we can talk about this in the pain sciences, she told me that she was having issues, a little bit of depression because her husband had passed away tragically a few years prior. So in my mind, I'm thinking, okay, so this is something that I need to keep in mind when I'm working this patient. There's an aspect to that may be affecting her symptoms. She was a non-smoker. She exercised every day. She was happy with her job. So those were my symptoms. Now, when I went into it and I did my exam, I started with the cervical spine because in my mind, you've got to start with the spine. So you start proximally, and I wanted to make sure that that wasn't contributing to her symptoms. So when I did that, I did my range of motion. I did my range of motion with overpressure. I did my PA assessment, quadrant, delved in there with different angles of application of force. And nothing that I was doing was able to provoke her thoracic pain. When I went further into the thoracic spine, she did have a localized area of tenderness on the right side. I was able to reproduce her pain in a right-sided quadrant extended type positioning. She also had pain with resistance to the mid and lower trap. So there was something that in my exam that I was able to work with. So that was something that I did with her. So I did all of my treatments in my orthopedic realm, doing manual therapy, combining with exercise. We discussed posture because she mentioned it was with sitting. So after the first treatment, she came back to me and she said, I felt better, and she felt significantly better. So I thought, yes, I'm moving in the right direction. Everything's going great. So I continue with my treatment with her. So I go into it with a little bit more vigor because I was able to assess early on that the irritability of this condition, despite the night pain, the irritability was pretty low. I could generate a decent amount of force, and in my questioning I knew that the time to aggravate was long, the time to ease was pretty rapid. So I got into there a little deeper, and again we had some success. The thing that when I continued to question what I wasn't generating any change was with the night pain. So over time she reported to me, I'm feeling better during the day, but for some reason I'm waking up at night, and I don't know why. So we talked about, okay, well, what can we change with sleeping? What postures are you sleeping? And we delved into that, and I went into it in great detail. And despite all of our efforts, that aspect of her treatment, I wasn't generating change. So in the back of my mind, I'm thinking, okay, I'm going to give this a few weeks, right? I don't want to take too long, but I really want to make sure I'm doing my job, that I'm providing the kind of treatment that I need to provide to make a change. So I wasn't happy that she wasn't improving in that area. So I had a discussion with her doctor, and we talked about the fact that yes, she did have some underlying depression. She was going through a difficult time with her husband. We knew all of that, and she was open to discussing it. She was seeing a counselor. She was diving into all different areas with that. But we still weren't generating a change. And so I said, maybe further examination is warranted. And so the physician agreed. He said, let's pursue this a little bit more. So they did imaging. Nothing showed up in an x-ray. And she was referred to an orthopedic physician, and because her primary care referred her to me. So I was working with her, and she thanked me for continuing to pursue this, that I wasn't happy with how she was doing ultimately, because we weren't getting what her primary goal was, to return to sleep. It's a big deal. So she saw the orthopedic surgeon, and they said, we can't find anything that's of concern to us. We think that it's musculoskeletal. Go back to your PT. So I said, okay. So I took a different approach, worked more on exercise, thought, okay, let's take a different aspect from this. I was thinking of pretty much pulling all of my tools out of my toolbox that I've done all these years. And still, I wasn't generating a change. I noticed when I was working with her that she started to lose weight. And I asked her about that. And I said, I noticed you're getting a little bit thinner. And is this something that you're trying to do? Or, please talk to me about that. And she said, I don't know why I'm losing weight. And she conveyed that she was starting to get a little concerned. And I said, I don't like this. You're losing weight, you're still not sleeping, and the sleep was that main variable that wasn't changing. So, a case like this, when you have a patient like this, even though everyone kept referring this patient back to me, she wasn't getting the goals that she had hoped to achieve with me. And despite my efforts as a therapist, I wasn't able to generate change. I generated a change during her day. She got temporary resolution of symptoms, but it was waxing and waning. And then we saw a progressive increase in the night pain. She was starting to lose weight, and her fatigue level was continuing to increase. I didn't like that. So I said, you know what? I know I've sent you back to your doctor, but I'm going to send you again. And she said, I really don't want to go back. And I said, well, we need to keep pursuing this because something about this isn't making sense. And she agreed. So she went back to her doctor, and I didn't see her. She didn't come back to me. And what happened with this patient, I got a letter sent to me, and I get a little bit emotional about this. I'm a little embarrassed, but this is our world, and we connect with these patients. So I got a letter from her, and she had passed away, and she wrote a letter before she died, specifically to me, thanking me for being her advocate. She ended up having pancreatic cancer. She was 45. She didn't meet all of those criteria, but in my mind, there was something that was wrong with this case. Something didn't make sense. And when you have that, it's our job as therapists to be our patient's advocate. If you're not getting a patient better, it is our duty to figure out why. It may be out of our scope of practice, but it is essential. It is essential that we direct these patients where they need to go. She thanked me for sending her back to her doctor because it was ultimately discovered. Now, I didn't save her life, but I didn't keep her in my clinic and keep treating her over and over with thoracic moans because it gave her temporary resolution of symptoms. It wasn't generating the exact change that we needed. And she told me in this letter, she said her dying wish for me was that I would teach other clinicians about her. And so I thought about this when I was thinking about what a great, Facebook Live to do. What a better platform than to teach this example, teach her case, affect all of you. When you get a patient like that has that waxing and waning of symptoms, even when you feel you've ruled out, never use the word rule out, by the way, rule in or rule out. We can never really rule in or rule out. You always keep that thought process. You keep that ongoing critical thinking, right? Ongoing. You never stop thinking. When a patient comes to you, you check the moment they walk in that clinic. You find out how they're doing that day. You reassess how they're doing with their subjective and functional aspects. So you test and retest. You check yourself. Do a self-assessment. If you're not getting the goals that you wanted to get with your patient, you are not achieving what you set out for, and you're not helping that patient. So I thought today that was my topic. I might have gone on a little bit longer than I anticipated. Actually, I think I'm doing pretty good with time. Listen to your patients. Be unbiased. Keep an open mind. Never stop critically thinking. Not for a second. Once you feel comfortable in the clinic, that's when you should do a self-recheck. When you're feeling too comfortable, something's wrong. You should always have a check and balances in yourself when you're working with your patients. Okay, so that's my topic. And I hope that when you see your patients, when you're doing your subjective exams and you're every time you see a patient, don't forget, always check, test, retest. And don't forget that differential diagnosis and the fact that a red flag could be that waxing and waning if we're not seeing that trend of improvement that we expect. Okay, have a wonderful day, and thank you for listening.